Hey guys, Jas here and welcome to another video. So today I'm basically going to go through a variety of different junior doctor rotations, and I'm going to give my opinion on how useful I think they are in regards to radiology training and being a radiology registrar. Now, the rotations that I go through later on in the video, those are the rotations that were offered to me as an intern doctor or a FY1 doctor at the hospital that I worked at. Now, I'll break all the rotations down into either I'll go through the medical specialties first, then I'll go through the surgical ones, and then I'll go through the other ones that kind of don't specifically fall into either of those categories. Now, if you are watching this video and you are from one of these other specialties that's not radiology, my intention's not to offend anyone. I'm basically just giving my honest opinion on what I thought while doing them, or from the feedback that I got from other colleagues and stuff that did the other rotations that I didn't get a chance to do. So please don't be offended. All right, so let's start with the medical specialties first. So number one is cardiology. Now, cardiology itself, I wouldn't say it wasn't particularly useful being a radiology registrar, unless you do have a passion or interest in, cardiac MRI, where, understanding the basic principles of cardiac physiology and all that kind of stuff can be quite useful. The other instance where it can be a bit useful also is if you do pediatric radiology, and then you happen to work in a center that does, congenital cardiac stuff. A lot of because the cardiac, the congenital cardiac abnormalities are very, very complex, and then obviously having an understanding of the cardiac stuff from a physician's point of view, more so physiology and obviously the pathology stuff as well, that can be useful. But otherwise, I would say that's probably about it. I don't really remember anything else that was particularly useful from cardiology. Like I said, unless, like I said, you've got special interest in cardiac imaging. Okay, number two is kind of infectious diseases or endocrinology. I've kind of just grouped them together because that's how they offered it at my hospital. I think more so because they're both smaller subspecialties and the inpatients and stuff weren't that high, so they just grouped them together. So they had one junior doctor looking after those both specialties. For both of those, I would say probably not very useful. Basically can't remember any antibiotics or dosages, so that obviously wasn't relevant in my radiology training. Probably shouldn't admit that on camera, but that's the truth. Endocrine, I think doing the term itself probably isn't that useful. The only time we really used to get involved with endocrinologists was we used to provide MDTs for them, and that was usually to do with thyroid lesions or parathyroid lesions as well. But again, maybe just a bit of basic physiology from the endocrine point of view, more so to do with thyroid and parathyroid function, and that could probably help you with sestamibi scans and stuff like that, which is all nuclear medicine. Again, if you have interest in that, but that's probably about it. Number three is gastroenterology. I would say this is probably one of the more useful terms. I did it myself, and again, the physiology, pathology, we see a lot of, obviously a big bulk of imaging that we do is abdominal. So if you have, CTs, MRIs, whether that's liver, pancreas, MRCP, etc. So having a good understanding of the, pathology, physiology to do with the gut and all that kind of stuff, so bowel stuff. Gastro, also do hepatology as well, so that's obviously quite useful, particularly from an imaging point of view, because we do a lot of liver imaging, and then whether it's cancer or other kind of pathologies, biliary pathologies, all that kind of stuff. So I would say that was a pretty useful term. And then on top of that, there's also, gastro is also a procedural specialty, so although you're not doing any endoscopy or anything as a junior doctor, but I used to go around and do all the acidic drains. We used to have acidic drain clinics and all that kind of stuff as well. So I think getting onto doing any needle work or procedural work from an early stage is very useful, because you'll be doing a ton of it as a radiology registrar and a radiologist. So gastro, I would try and do that if I was, I did it. So if I was in your shoes and picking terms, I would definitely consider doing it. Number four, geriatrics. I can't say that it was particularly useful. That's it. I can't say that it was overly useful. Okay, next is number five is hematology. Hematology, I can't say was, from a radiology point of view, not particularly useful. Like, obviously it's a good term in just being a good general junior doctor, because the patients are quite sick, they're quite complex with all the, hematological malignancies, other problems, etc. So from a junior doctor point of view, I would say in general it's a good term. Radiology wise, probably not as useful. Obviously we do a lot of PET imaging and stuff like that for patients with lymphoma. So there's a bit of crossover there. But it's probably not one of the ones that I would say, yeah, you should definitely do it. Number 6, immunology, rheumatology. Again, these two are grouped together because they were like kind of smaller specialties in my hospital. Immunology, yeah, not particularly relevant. Rheumatology, from a clinical point of view, I don't think it's overly useful. So the pathologies are good to know because we do see obviously a lot of them. So all your arthropathies and stuff in your hands, the spine stuff, they're all going to be getting imaging. They've all got particular patterns that you can pick up on imaging to help with the diagnosis. So it can be good from that point of view. If you're doing that term, your patients are getting imaging. It's good from a learning point of view from the pathology. That could be good and useful. But I would say that's probably about it. Next, number 7 is medical assessment unit. Every hospital has like a different name for this kind of placement, but it's kind of that general medical ward. Usually the patients have just been admitted through ED and then they kind of stay there. I think it's more of like a short stay unit sometimes. Where they can try and get on top of the patient and hopefully discharge them home once they're well enough. For MAU, I don't think it's particularly useful, more so because it's a very general kind of term, general medicine, that kind of stuff. So from a radiology point of view, most of the imaging or the acute stuff's usually addressed in ED, and then they're usually admitted to this ward once they're stable or not really got much going on. So at least that's my understanding anyway. So I don't think it's particularly useful. Number 8 is palliative care. This term, I would say, a lot of the time, obviously, once the patients reach that stage and they're in palliative care, there's not really going to be too much more. Generally, there won't be really any investigations, as it's more so about, comfort care and, just making sure the patient's really looked after and comfortable. So it could be good from a point of view, as in a lot of these patients would have had, quite significant pathologies, comorbidities and all that kind of stuff. And, whether it's because of malignancy or something like that they've ended up in this ward. So from their previous history and their previous imaging and all that kind of stuff, that could be quite helpful, as you can kind of see disease progression. And then also the different scans. A lot of the times these patients have had a lot of different types of intervention, usually performed in radiology for comfort care. If, say, a patient with lung cancer's got massive, malignant pleural effusion, and then they, do a pleural drain or a pleural tap to try and reduce that volume and improve the patient's breathing, then that could be good to see and get experience. So that's what my thoughts on palliative care. Next one is radiation oncology. Again, this one's got radiation in the name, so it can be good from a point of most of the patients, because obviously when you're a junior doctor, your job is more so to look after the patients on the ward. So the radiation oncology registrars are usually in in clinic, where they're seeing their patients, planning radiotherapy, etc. So I did this term. You don't get a whole hand as a resident. You're not in the clinic, obviously, because that's what the registrars are doing. So you're on the ward. So it's more like an oncology kind of term where you're looking after cancer patients. I guess the good thing, if you do manage to get down to the clinic or see the radiotherapy planning, it's quite hands-on with all the medical physicists and the techs, etc. So for the Part 1 exams that we have to do for radiology in Australia, there is 2 physics exams. So getting a bit of understanding or a bit of exposure to physics can be quite useful for those exams. So not a bad term to do. Next one is neurology. Neurology, as in neurology. That's quite a good term. A lot of imaging involved with neurology patients. And obviously the other big thing is the stroke patients who do get admitted to the neurology ward. So there's obviously a lot of neuroimaging there, perfusion and stroke imaging, a lot of MRIs, and then obviously some spinal pathologies that are also managed by the neurologist, so spinal MRIs and imaging as well. So I think pathology-wise and imaging exposure-wise, it'd be quite good. So that could be one to consider for sure. Next is nephrology or renal medicine. Not a huge imaging aspect to renal medicine or nephrology. Every now and again, there might be a patient that's either obstructed And if urology, as in urology with a U, doesn't want to put in a stent, then we do nephrostomies. Or if they don't want to put in a stent straight away, the interventional radiology guys get involved and put in a nephrostomy tube. So can be good from seeing that, but how many nephrostomies do you really want to see? And I don't think if you're the intern or the junior doctor on the nephrology ward, I don't think you'll be doing the nephrostomy. So I guess if you've got interest in it, then it could be something to do. And lastly, for the medical ones is respiratory medicine or pulmonology. This is quite a good term in regards to, I guess, pathology wise, like when it comes down to lung cancers, a lot of imaging. The MDTs are very good. And as the intern, you'll get to attend them, so you'll get to see the whole patient, diagnosis, how they went about it. Was it a CT guided lung biopsy, or was it bronchoscopy guided biopsy? And then also the whole staging system for lung cancer, and then what the surgeons will come in and resect, what the oncologists think. So that's quite good. And then also the other aspect is all the actual interstitial lung disease and all the other varieties of lung parenchymal pathologies. That's a big, there's a lot of different entities involved within interstitial lung disease. There's a big imaging component to that as well. So HRCT, the chest, that's a big one, and just seeing all those pathologies, and then being in the respiratory team, you'll get to see the clinical stuff as well, respiratory function tests that go along with the imaging findings and the patient's presentation. So, and then on top of that, it's also the procedures too. So the respiratory guys are doing their bronchoscopies, which is quite cool. But then on top of that, they'll do pleural drains as well. A lot of the times they'll do it, or my hospital, they'll send them down to radiology as well, or we'd do it. So you get your hands a bit dirty as well, which is good. So I think respiratory medicine's a pretty good term to do. All right, so now moving on to the surgical specialties. So number one is colorectal surgery. My general preface for all the surgical specialties is that I think they're quite useful just in general. The pathologies that you see, there's a lot of intervention. A lot of the times before they do surgery, they'll get radiology to potentially do intervention like a drain or something like that. So in general, the surgical terms I think are quite good to do, and I kind of favoured them over the physician-y medical ones. But I'll run through the different surgical specialties now and kind of give you a bit of a run through. So number one, colorectal surgery. Again, good for pathology, good variety of different types of surgery. So I think it is, if you can get it, it's a good term to do, or if it's the surgical specialty that they offer to you, then it's good. The next one's trauma surgery. Trauma surgery is quite good because the patients that are usually presenting, a lot of the time they'll have multiple pathologies. I guess it depends on how bad the trauma is, but usually with all these patients, they would have had probably a CT pan scan at least, so a lot of imaging to go through, and then obviously the surgeries themselves, big variety of surgery that you can see. So again, good specialty to do. Next one is vascular surgery. Again, quite a good one. A lot of imaging, CT angiography, then the interventional guys. Sometimes the interventional radiology guys will do a lot of cases with the vascular surgery guys themselves. So whether that's like DSAs, diagnostic kind of angiograms, or even a lot of the times the endovascular grafting, like AAA repairs and stuff like that, they'll usually work together to do the procedure and manage the patient. So that's quite cool. And then a lot of the venous stuff as well. So sclerotherapy, etc. A lot of interventional radiology in that, or the vascular surgeons as well. So there's a lot of crossover with a lot of the procedures there between the interventional radiology guys and the vascular surgeons. Obviously the interventional radiology guys aren't doing open surgery or anything like that. It's all endovascular or that kind of stuff. So that's quite cool. So big overlap there. And the pathologies themselves, quite interesting. I guess the only negative there is that you're dealing with a lot of patients with high comorbidities, a lot of vascular issues, renal issues. So as a junior doctor, you're going to be getting a lot of kind of consults from other specialties because the patients usually have got a ton of things going on. And then the other, probably the worst part of the term, because I did it, is you're dealing with necrotic feet. And they smell bad. So brace yourself if you are doing the rotation. Next is upper GI surgery. That kind of obviously falls into general surgery. At the hospital I worked at, Obviously, they've had a biliary surgery that they're looking after. A lot of complex pathology, which is good. A lot of imaging, a lot of intervention, like drains and stuff that are performed in radiology. So that's also interesting. And you can kind of get involved and go down with your patients and, you know, get amongst the radiology department there as well. Obviously, the negative, a lot of these patients are very, very sick. You know, particular patients that have got like, you know, chronic pancreatic pathologies or, you know, the malignancies involved, like whether the biliary malignancies, pancreatic, all very, very sick patients. So that's obviously something to be mindful of, but I did the term. It's a very good learning opportunity. And I usually tell people, like, if you can make it through that term as an intern or a junior doctor, like, you're pretty set, because it's usually one of the hardest ones for any junior doctor. Next is kind of head and neck surgery or ENT surgery. Again, it's good. A lot of imaging involved with the head and neck cancers. There's always a head and neck MDT, which is usually quite high end and usually good to attend. Head and neck MRIs, obviously quite complex, but good to get exposed to. Get a bit of exposure there, and yeah, again, just another useful term. And then just to quickly run through there's obviously most of the ones, like I said at the beginning, all these specialties are quite good. They all got useful things. So the neurosurgery, cardiothoracic surgery, orthopedic surgery, and urology. Neurosurgery, again, your patient's going to be quite sick, but again, a lot of imaging. And the rest of them, again, like just seeing the different pathologies, just being in specialties where it's quite hands-on, a lot of procedures, it's just useful. All right, the next subset of specialties is critical care ones. So I maintain these ones are probably the most useful for being a radiology registrar. So that kind of encompasses ED, ICU, anesthetics. They're all very good, and I would recommend doing all of them. A lot of the time, ED is compulsory for all junior doctors. Like each year, you'll probably have to do an ED term. At least that's the case in most of the hospitals around where I trained. So ED is good. Obviously, you're working on the entire patients. You take histories. You do see the pathology. You're essentially going to be requesting imaging for probably all of your patients. So that's good. It will kind of get that interaction with the radiology department, and then you can you see all the different types of scans and the pathology that you get from the scans. So, and it's quite hands-on. Obviously in ED, you'll be doing quite a lot of procedures as well, which is good. So ED, which I'm guessing you'll probably have to do, but a good term to do. And then ICU, again, excellent term. Now, the level of medicine in this is obviously a notch up. Your patients are very, very sick. They're the sickest patients in the hospital. So it's good to see that, good to see the complex pathology and usually multiple pathologies. And your patients are probably going to be getting, frequent imaging as well, which is good. So you'll see that. And then you can kind of link it up with the clinical stuff that you're seeing. But the best thing about ICU is all the procedures that you get to do, particularly all the lines that you'll get to practice. So, whether they're arterial lines, kind of venous catheters, like internal jugular vein catheters, radial artery catheters, etc., etc. It's very good to practice those because most of the time, sometimes maybe not with a radial artery line, but like a more deep arterial line, like a femoral one, or any other, venous catheter as well. You're going to be using ultrasound most likely. So practicing those ultrasound skills is quite good, and it is something that the radiology people or panels that are doing selection will look upon favorably. So highly recommend doing ICU. And then anesthetics is kind of similar again. You get to see, good physiology, but again, it's also a good specialty for practicing lines and all that kind of stuff. So anesthetics is good. So definitely recommend that if you can get it as well. All right, guys. So now this is the last category. It's just kind of my other category. So basically what falls into this is O&G, pediatrics, and psychiatry. Psychiatry, I don't think it's useful really for radiology. Obviously nothing against the specialty, but there's not really any acute pathology that we see from an imaging point of view. They will order like CT heads and, MRIs of the head for part of their organic screens, but a lot of the time it's negative. And so nothing really that I could suggest or recommend from psychiatry towards being a radiology registrar or radiologist. O&G can be a good specialty. It's obviously got a big hands-on component, which can be good. Some of the pathology, I guess, the obstetrics part is probably more useful from an imaging point of view, particularly if you can get into like a maternal fetal medicine kind of unit or go to the clinics and stuff like that. The imaging in that is very advanced, the obstetric ultrasounds that are performed. and then you'll kind of get an idea of all the complex chromosomal abnormalities that can occur and what the imaging findings from that are, because a lot of the time in the clinic itself they'll be doing obviously hands-on scanning at the time, so seeing that in real time is quite good. So I would definitely recommend that component of O&G. And then lastly, pediatrics. I think pediatrics, there's a lot of imaging involved. You'll pick up your ultrasound skills, like that's obviously the modality of choice for children. So then, linking that up with some of the pathology that you might see. I guess it depends also on the level, or how big the hospital that you work in is and what kind of pediatric service that they provide. If it's more of like a general pediatrics thing and like kind of more low end or developmental kind of type stuff, then obviously that's not as useful. But where I did my training, I was at a high end, like tertiary level or maybe quaternary, but they had all the complex cardiac stuff, and and there was like heaps to be learned. So that was an excellent term which I really enjoyed. So I guess depending on where you're trained from that point of view, it could be useful or maybe not as much. All right guys, so that brings me to the end of the video. I know that was a lot of talking, but basically that's my kind of interpretation or how I feel about the various rotations that you can do as a junior doctor and whether or not I think they are helpful for radiology training or being a radiologist. I hope you found the video useful. If you did, please consider giving it a thumbs up and subscribing to the channel if you're new, and I'll catch you on the next one. Cheers.